Okay, so it's about electrolytes, what you need to know in laboratory practice. So this is the outline, the physiology of electrolytes followed by pathology, which includes electrolyte imbalances, then the measurement of electrolytes, and finally the interferences. Electrolytes are osmotically active particles which can be classified by the charge of them. Those include sodium, potassium, calcium, and magnesium. Those are the cations, and the anions include chloride and bicarbonate. The control of electrolytes is based on water and pH balance, and water accounts for approximately 60% of body weight, and a healthy person, the homeostatic mechanisms take place in the body to maintain the composition of electrolytes and water within a narrow limit. So there are two main situations in which these electrolytes are requested by the clinicians. These electrolytes abnormalities can be seen in a wide variety of disorders, and you know, in inward patients, most of them are given IV fluids. So administration of fluids require reassessment of electrolytes and osmolarity. What are the functions of electrolytes? They control osmosis of water between body fluid compartments and help maintain the acid balance, and they are also important in myocardial rhythm and contractility. They serve as cofactors in enzyme reactions which occur in the body. So these are the medically significant and routinely ordered electrolytes. Those are sodium and potassium. I will discuss them about in detail. The sodium is the most abundant ion in ECF, approximately 140 millimoles per liter. It has an important role in fluid and electrolyte balance because it attracts fluids and preserves fluid volume. It can combine with chloride and bicarbonate to regulate acid-base balance, and it's freely filtered by the kidney glomeruli, and 80% is reabsorbed in the proximal tubule. The excretion is through feces and sweat and the kidneys. Sodium and water homeostasis is linked because water follows sodium always. The clinical effects are due to movement of water in and out of cells. Potassium is the most abundant cation in ICF. It has a key role in establishing resting membrane potential in neurons and muscles, and it helps maintain ICF fluid volume. So at a cellular level, this sodium and potassium is maintained by the action of sodium-potassium pump, which uses active transport to move molecules against the concentration gradient. So it pumps out sodium, and potassium will be pumped inside to cells. And remember, insulin enhances potassium entry into cells, whereas glucagon inhibits it. So this is the distribution of water, sodium, and potassium. As you can see, the potassium is the main cation in ICF, whereas the sodium is the main cation in the ECF. So let's have a look how these electrolytes are maintained within the body. So there are osmoregulators in the body, and when there is an increase in osmolarity, those osmoreceptors get stimulated, and they activate two types of protective responses. One is the stimulation of thirst center, which stimulates water intake, and there will be increased ADH production as well. So these responses are triggered by a change of osmolarity of 1%. And there are volume regulators as well in the body, and when there is a decrease in the arterial volume, that will be sensed by the volume receptors in the hypothalamus, and they activate three types of responses. there will be stimulation of the thirst center, and there is increased production of ADH, and in addition to that there will be activation of renin, angiotensin, aldosterone system. So these responses will be triggered by a change of volume of 5%. The major hormone which regulates water loss is ADH, that is the also called actually vasopressin, produced by the hypothalamus and released from posterior pituitary in response to high osmolarity and low volume. So it acts on the V2 receptor in the this collecting ducts, and it promotes insertion of aquaporin 2 into cells, and that will lead to increased permeability to water. So more water will be absorbed, and therefore it will produce concentrated urine. So this is again the same thing which I described. I'll just skip it. This is about renin, angiotensin, aldosterone system. So when there is a decrease in the arterial volume, here then the renin is produced by the juxtaglomerular apparatus. So that will increase the production of angiotensin 2, which acts on the posterior pituitary to secrete ADH. Then ADH will act on the collecting ducts. So it will lead to increased absorption of water, and so there will be water retention. So this angiotensin 2 also act on the adrenal glands to secrete aldosterone. So this aldosterone again act on the distal tubules and collecting ducts. So it will lead to increased tubular reabsorption of sodium and potassium secretion. So again this will increase the water retention. So when there is water retention, there will be an increase in arterial volume. So it will inhibit renin secretion. So natriuretic peptides also play a role in sodium regulation, mostly sodium. So those are ANP and BNP, atrial natriuretic peptide and brain natriuretic peptides, produced in the heart in response to cardiac stretch. So when there is a volume overload, these natriuretic peptides will be produced, and they decrease sodium reabsorption and also renin and aldosterone production. So that will lead to decreased plasma volume and serum sodium. So the two hormones which regulate sodium reabsorption include aldosterone and ANP. A little bit about potassium regulation. It is not closely regulated. Most potassium is reabsorbed in the proximal tubule. The regulation occurs mainly in the distal tubule through the action of aldosterone in the presence of either hypo or hyperkalemia. There are additional factors in potassium regulation. There is a component of renal regulation through this potassium hydrogen ATPase pump, which facilitate potassium reabsorption in the distal tubule. And there is this sodium potassium pump, and pH is also important because when there is alkalosis, potassium moves into cell, and in acidosis vice versa happens. So this is the normal range of electrolytes. So we call hypokalemia or hyponatremia when these electrolytes are low, and when they are high we call it hyperkalemia and hypernatremia. So the clinical symptoms and signs vary according to the degree of severity. Remember, there are pseudo abnormalities as well. They can be pseudo hyperkalemia or pseudo hyponatremia. I will discuss them later. Dyskalemias are life-threatening disorders. So they are hypokalemia or hyperkalemia. So they affect excitable tissues like muscle and lead to muscle weakness and paralysis. They can also cause cardiac arrhythmias and conduction defects. So these are the causes of pseudo hyperkalemia. thrombocytosis. Then there are hereditary forms which will increase the potassium permeability of RBCs, like in somatocytosis and xerocytosis. And in acute myeloid leukemia and in chronic lymphocytic leukemia also you can see pseudohyperkalemia. Dyskalemia can occur when there is a change in intake or excretion, or when there is a shift in ions. These are the common causes of hyperkalemia. Decreased renal excretion in acute or chronic renal failure. Then some drugs can also cause hyperkalemia. Drugs such as diuretics, ACE inhibitors, beta blockers, NSAIDs and digoxin. And you can also see hyperkalemia in diabetic ketoacidosis and other metabolic acidosis due to iron shift. There are some other causes as well. And you need to inform the clinician if serum potassium is more than 6 millimoles per liter, but this can change if the patient is already a known patient with chronic kidney disease. The common causes of hypokalemia include increased loss through kidneys or through the GI tract, or when there is a transcellular ion shift which is seen in metabolic alkalosis or insulin overdose. And again 2.8 is the critical value, so you need to inform the clinician if serum potassium is less than 2.8. Moving on to sodium disorders, hypernatremia, that is high serum sodium. So it can be renal or non-renal. Non-renal can be due to increased water loss through GI tract or skin. And increased renal loss of water can be seen in disorders such as diabetes insipidus or diabetes mellitus. Remember, infants and elderly individuals are prone to get hypernatremia if they are deprived of sufficient amount of water. The high salt intake can also cause hypernatremia. That is rare actually, but you might see patients with hypernatremia when they are given hypertonic saline, like 3% saline, or when they are on IV sodium bicarbonate. So the cutoff, the critical cutoff we take is 150. So you need to inform the clinician if serum sodium is more than 150. These are the clinical effects of hypernatremia. So they can vary according to the degree of severity. So they can present with polydipsia, polyuria, and sometimes with lethargy, weakness, or sometimes even with seizures depending on the severity. Hyponatremia can also be renal or non-renal origin. They are classified according to the hydration status. And remember, the concentration of sodium in a spot urine sample is very important in this condition. And there are some instances that you see even the actual total sodium is high in the body. You will see hyponatremia due to the dilutional effect, and those instances include nephrotic syndrome and congestive heart failure. So these are the differential diagnoses of true hyponatremia. Remember, in euvolemic patients, this syndrome of inappropriate ATH secretion is one of the main differential diagnoses. Even hypothyroidism and cortisol insufficiency can also lead to hyponatremia. These are the clinical effects that you get in hyponatremia depending on the severity. So the patients can present with headache, depression or unstable gait, and sometimes, most of the time, we see patients with confusion and nausea, and sometimes they present with even vomiting and seizures. And again, remember, the symptoms also depend on the rate of development of this hyponatremia, depending on whether it's acute or chronic. When you get acute hyponatremia, you get these symptoms, but we don't see these symptoms in chronic hyponatremia. So remember, you need to alert clinician if serum potassium is less than 2.8 or more than 6, and if serum sodium is less than 125 or more than 150. These are the methods that we use to measure electrolytes. It can be flame photometry, ISC, or atomic absorption spectrophotometry. But flame photometry we don't use nowadays. The most common method that we use in our laboratories is ion selective electrode. So it consists of reference and ion selective electrode, and this ion selective electrode is covered with a particular membrane which is more selective for this particular ion. So when this ion comes in contact with the electrode, a change in the potential can be observed compared to the reference electrode. So this is measured as a voltage change due to the ion activity. So these can be direct or indirect. In indirect method, remember, there is a dilution of the sample. So this is the method that we used in our analyzers, most of the time, automated analyzers. And this method is actually affected by protein and lipids. In the direct method, there is no dilution of the sample. It measures activity in the aqueous component in plasma, and this method is used in the blood gas analyzers and vitreous analyzers. The specimen that we use to measure electrolytes can vary. It can be serum or this lithium heparinized whole blood, which is used in the blood gas analyzers, and we can also measure electrolytes in lithium heparinized plasma. And remember, plasma is the sample of choice because it has less potassium compared to serum. And we can also measure electrolytes in urine, either in random or 24-hour collections. Moving on to interferences, the pre-analytical errors can also occur. So the type of anticoagulant is also important. When there is an excess anticoagulant, it can result in dilutional effect causing low sodium and chloride. So this can occur when you use blood gas analyzers. So if you don't use the correct sampler, we can see this. And when the anticoagulants such as trisodium citrate and EDT are used, you know that it can chelate cations, and contamination will lead to spuriously high sodium or potassium. The hemolysis also can increase serum potassium due to release of intracellular potassium. And the gross hemolysis will lead to hyponatremia because of the dilutional effect. The storage condition is very important because refrigeration of unseparated whole blood enhances release of this intracellular potassium. So it can lead to hyperkalemia. Drip arm contamination is another pre-analytical interference that we sometimes see in our results. So remember, these are the IV fluids which we use in the hospital setup. So normal saline has around 154 millimoles of sodium and chloride, and 5% dextrose has glucose, and 4% dextrose and this 0.18 saline has both glucose and electrolytes. So when there is drip arm contamination, osmolality is usually normal, but there will be again there is a normal osmolar gap as well. So to identify this drip arm contamination, you can actually measure glucose, albumin and protein. So when you look at a patient result, you should be able to identify whether it's an artifact or whether it's pathological. Analytical interferences include pseudohyponatremia. So this occurs in indirect method because there is sample dilution. So this can be seen with when the serum samples have high concentrations of lipids or proteins. So they display some of the volume of the plasma within the dilution and can result in falsely low sodium and chloride. So when the triglycerides are over like 30 millimoles per liter, or when proteins are more than 100, you can see this effect. So in pseudohyponatremia, the important thing is measured osmolality is normal, but there will be a high osmolar gap. Again, remember, even with normal water content, there can be a slight difference between when you look at the electrolyte results between this direct and indirect method. There can be a slight difference. The electrolytes in urine is also an important investigation when you are when you are when you want to narrow down the differential diagnosis. Most of the time, urine electrolytes are done when there is hypokalemia or hyponatremia. So it is the spot urine is the most useful one, and we usually don't use a normal range. We use this 20 millimoles cutoff only when this patient has hypokalemia or hyponatremia. And 24-hour urine is also important, but it reflects actually daily intake, and this can be useful for assessing replacement. These are the closing remarks. So electrolyte measurements are very common. Sodium and water must be considered together. Diagnosis of disorders require both clinical and laboratory investigations, and urine samples are also important. Thank you.